Hi there, and welcome. My name is Jeff Bell, and on behalf of McLean Hospital, I'd like to thank you for joining us for yet another episode of our educational webinar series. Our focus today, narcissistic personality disorder, or NPD. It is a complex topic to be sure, especially given the many misconceptions about the disorder. To understand what it is and is not, we need to take a look at both the healthy and the problematic ways that we can see ourselves and the impacts of those perceptions. To help us do that, we have invited Dr. Igor Weinberg to be our guest. He is someone who specializes in the assessment and treatment of personality disorders, including NPD. Igor, thanks so much for making time for us.
Thank you so much for inviting me.
Well, when it comes to this topic, it strikes me that there is some very critical, often misunderstood vocabulary that we should address. So let's do that, starting with the term self-esteem. What specifically does that term get at?
Self-esteem usually, which is a very broad term, it usually gets at different thoughts and feelings and opinions, including evaluations that people have about themselves, good or bad. And it's a very broad term because we know that there are actually some other definitions that exist in the field. So I guess if we're just sticking with the definition, I would just keep it at that.
Okay, and how about the term narcissism itself?
Well, narcissism is a very complex term. It probably has more literature, especially in psychoanalysis, than or practically any other term. It really invited a lot of people to think about this. Um, and in psychiatry, we have some research that accumulated in the last 2 or 3 decades. Um, and we can talk about specifically about narcissistic personality disorder, which is a disorder that is related to pervasive pattern of grandiosity, but also entitled behavior and entitled expectations, but also fantasies of success, fantasies of beauty and special treatment, but also exploitative relationships, difficulties with empathy, and tendency to presume that other people are envious of them. And this is a grandiose version of narcissism. When we're thinking about narcissism in general today, we're also recognizing that this is a very limited definition. There is another version of narcissism that's called a vulnerable presentation that includes a somewhat different presentation that people may not be overtly presenting with a sense of grandiosity. They could present with a lot of reactivity to criticism, a lot of reactivity to rejection. They could be sensitive and also respond with aggression or anxiety to those type of things. But the commonality is that the sense of entitlement that present in both presentations, and with a wider definition, there is a greater recognition that the definition that we have in DSM of narcissistic personality disorder captures only a small number of individuals, and there's a wider number of individuals that could be covered by this idea of what we call pathological narcissism.
There often seems to be a negative connotation attached to the term itself, narcissism. But is it correct to say that there is such a thing as healthy narcissism, that it serves a function in our world?
Cannot be said better than this. I completely agree with this. The term narcissism is usually seen in a very negative light, including by mental health professionals. And I hope that our talk today can help address some of those issues. Literature also describes what's called healthy narcissism, and that usually covers things like healthy ambition or charisma or even sense of humor. Those type of things could be related to healthy narcissism, and they're certainly admired and they're helpful. They help individuals to move forward. They help society to move forward. But it also helps groups of people to function in a much better level when they have like a healthy leadership, for instance.
Igor, as we mentioned, we're going to zero in on NPD today, but
Of
we
course.
also hear this term pathological narcissism. Is there a distinction between that label and NPD?
Yes, absolutely. Pathological narcissism is a wider and a broader concept that usually includes the grandiose version, which is mostly covered by NPD, narcissistic personality disorder, and a vulnerable version, which is people that are not necessarily presenting with overt grandiosity. They're much more they're struggling with regulating their self-esteem, usually by very specific investment in status or achievement and things like this. And they literally feel dependent on those things like oxygen because to them, it feels like their self-esteem is always crumbling and always lacking in something. Um, so it's much broader definition.
Usually, I would wait a little bit later in the webinar to ask this question, but I want to put it out there now so
Yeah.
we can debunk some of these myths. Talk, if
Yeah.
you would, about some of the common misconceptions around NPD, because there are many.
But there are many. First of all, we can talk about the language. We can talk about narcissistic personality disorder or narcissism. And usually, especially if you go on social media, you find how vilified this concept is. And people with NPD are usually being seen as bullies, as abusers, and people that completely lack empathy, and all they want to do is upset other people and hurt other individuals. And while those behaviors do occur, we also know that there's a great complexity in that narcissistic personality disorder has other dimensions, not just that. And a lot of people with pathological narcissism, including NPD, may not be acting in this particular way. Also, what they may not be acting, they may not be doing it intentionally. A lot of times the assumption is that it's all done intentionally, and that makes those people really evil. And that's a lot of times the undertone. And that's a very unfortunate assumption because, first of all, it prevents us from seeing people as they are, seeing the individual behind the disorder with the complexity. But also, it prevents people with NPDs seek treatment because they already expect that there's a lot of stigma.
And we're going to hopefully address that stigma as we go
Yeah,
throughout the webinar
yeah,
today.
yeah.
As you know, Igor, one of our goals is to weave in audience questions as we go, and we have many of those coming in. So let me just, at this juncture, when we're talking about vocabulary, ask you this on behalf of a viewer: is vulnerable narcissism the same as the recently popular term covert narcissism?
It's a very good question because depending who you ask, people may or may not agree with this. And according to some classifications, people might say that covert narcissism is greatly overlapping with vulnerable narcissism. According to my experience and read of the literature, those are two different dimensions. So we could talk about the two overt presentations of pathological narcissism. One of them is a grandiose version, which overlaps with NPD. Another is a vulnerable version, which I described earlier. And then there is a covert presentation, which is an interesting and very complex dynamic when people essentially go underground with with overt presentation, with their experiences of narcissistic vulnerability, and they act as if they're not really vulnerable that way. Usually it happens as a result of humiliating experiences where they're being shamed or humiliated for having any needs related to self-esteem, admiration seeking, achievement seeking, and they essentially dissociate or keep secret a lot of those dynamics. They're still affecting their behaviors, but they act as if they're really not present. And so what we find is that those individuals could present very similarly when it comes to intimate relationships. And that's how we usually know that there is something going on in terms of the narcissistic functioning, because the intimate relationships are very, very difficult for those individuals to sustain. But they could present as if they're very anxious, or they're suffering from depression, something like this. And many times they get misdiagnosed. Yeah.
What do we know about the prevalence of NPD?
We have prevalence for NPD, not so much for pathological narcissism at large, because it depends on the definition. The prevalence of NPD is estimated around 1% in general population.
About 1%. Okay. And can you provide any kind of historical perspective on the evolution of the DSM definition of what NPD is, how it might have been classified in previous years relative to how it's being classified today, and so forth?
Yeah, NPD it's a relatively, it's been part of DSM for many decades. It went through a number of revisions, but by and large, the diagnosis remained pretty much the same. I think the biggest addition was the introduction of the dimensional model unlike the model that we use, unlike the categorical model that we're all familiar with. The dimensional model opens up this definition for inclusion of people that really have a vulnerable presentation and other slightly less typical presentations of pathological narcissism because it has greater ability to recognize the specific expression of pathological narcissism.
Sounds to me it would probably make some sense at this juncture to walk through those two primary forms of pathological narcissism, grandiosity and
Yeah.
also the vulnerable.
So let me think. So the vulnerable, so the easiest one to walk through would be the grandiose presentation. So those are the people that, while they struggle with regulating their self-esteem and struggle with deep-seated sense of inadequacy, inferiority, shame, and humiliation, they usually overcompensate by presenting a more grandiose image of themselves. They usually seek recognition, seek admiration, and in terms of their interpersonal relationships, they tend to actually put themselves up and put people down. And this is one of the prototypical strategies for people with grandiose version of narcissism to regulate their self-esteem is by essentially putting other people down, sometimes in their minds and sometimes in their lives. They do it through criticism, humiliating comments, and some other behaviors. Sometimes they could act in this way. And that in this way, they try to regulate their self-esteem so they would continue to feel some sense of superiority over other individuals. And that would lead to also difficulties with empathy, which people know so much about, and fantasies of ideal love, for instance, or unlimited success, things like that. Those also would be the individuals that might feel that they're above the rules, that they don't care so much about the rules because they're so special and so unique. And so that sense of specialness is something that they're also known for. And that has to be contrasted with a more vulnerable presentation, even though it's actually a very unfortunate term because you would think this is vulnerable. And but there's nothing vulnerable about this presentation at all. It's just people act because the internal experience is experience of constant vulnerability. And the experience is that they have so little self-esteem that they have to hold on to any marker of external self-esteem to feel good about themselves. And the markers could be professional success, it could be appearance, it could be a certain type of relationships people have, it could be pretty much anything that has some type of a meaning from them. But they hold on to those markers as essentially a source of oxygen. And it becomes what we call sustaining resource for them. And if they lose that sustaining resource, it's devastating. They feel devastated because they have basically nothing left to base their self-esteem on. And so those are the individuals that also likely to respond with great disappointment, aggression, and if they don't get the recognition or they get rejected. And many times they respond with rejection, actually, too. Many times for those individuals, rejection is the experience that's so incredibly painful. And so that would be the two different forms that we think about. They can be distinguished one from another based on how they regulate emotions. So, for instance, people with more grandiose presentations tend to respond to failure with a lot of emotional reactions. And at the same time, people with vulnerable presentations tend to respond to rejections. Rejection are really difficult for them. But also interpersonal style could be quite different. For example, people with more grandiose presentations are usually marked by the triad of admiration seeking, rivalry, and retaliation in the interpersonal relationships. When it comes to vulnerable version, it looks a little different. It looks like the relationships are marked by coldness and intrusion, and also some sort of avoidance. So it's a triad of avoidance, intrusion, and coldness. So they could be distinguished one from another. And also research supports for the most part that distinction that the grandiose version is really based on kind of perfectionism in terms of relationship with other people, always expecting more from others and always feeling that people are falling short, and dependence on sustaining resources for the vulnerable version. So we could talk about this distinction, and yet we also find from the research perspective that they overlap, and the same individuals many times present with both facets of the pathological narcissism, so they're not really mutually exclusive. They really two sides of the same coin, especially people that are high in grandiosity. They tend to present with both facets.
You anticipated my next question, and that
Yeah.
is the fluctuations. Well, what
Yes.
do they look like? I mean, is it a cycling? Are there patterns going between the two, or how does
Yeah.
that play out?
It's a very good question because those two facets may seem like two sides of the same coin. It may seem like a Dr. Jekyll and Mr. Hyde, or it looks like this. And some people might think, well, maybe that looks like a bipolar disorder, but it's really not. We're talking about two different ways in which people organize around that self-experience of inferiority, humiliation, and shame. They really have troubles regulating those experiences and developing a consistent and positively toned self-experience, going back to the questions about self-esteem. And those become two main strategies in which they organize. And so when one is not working, they could flip to another, for instance. And so for some people, what we see is that in some areas they present in a more grandiose way, and in other areas they could present in a more vulnerable way. That could be one way in which it happens. For other individuals, it goes kind of, they fluctuate over time. And so one week people may present in this way, and the next week they could present a little differently based on the circumstances. And that's true in general about pathological narcissism. Some individual may think that this is a very fixed presentation. The reality is that it's very fluid and it's very context dependent. Depending on the context and the interaction of the person with the context, people could present slightly differently because sometimes it's affected by efforts to avoid criticism or efforts to conceal things that could be seen as shameful, at least in the eyes of the person, or sometimes it could be affected by self-enhancement presentation. And so the presentation of a lot of people with pathological narcissism could be quite fluid and may not be the same way. And one particular type of fluidity is from a grandiose to vulnerable, and then back from vulnerable to grandiose presentation.
Interesting question just came in from a viewer. Does NPD present differently depending on whether someone is an introvert or an extrovert?
I mean, in general, we see that grandiose version is more extroverted, and then the vulnerable version is more introverted in a classical sense of those terms. But again, people could flip back and forth, and you could see that somebody who was extroverted becomes introverted. And
What do we know
depending on
about the?
context.
I'm sorry, I didn't mean to cut you off there.
No, that's okay. Depending on the fluctuations that could go from the more introverted to more extroverted presentation. So
What do we know about causes? Is there a genetic component here?
this is also a relatively new subject. The very, very few studies that study genetic contribution, they're actually quite remarkable, actually, from that perspective. One of the studies pointed out that there's the heritability of narcissistic traits, not necessarily the disorder, is about 71%. And this is a very large number. That's much larger than some other personality disorders, and certainly larger for even some of the axis 1 disorders. And that leaves relatively small room for environmental influences. Just to be clear, most of the research, most of the theorizing, at least, about development of pathological narcissism emphasized the environmental influences of the family. And this is a finding that says, well, wait a second, maybe there's more to be said about genetics. I still think it has to be replicated in studies to make sure that we really that this is really 71%, and there's so little influence for the environment.
What diagnosis? What does that process look like diagnostically when it comes to NPD?
Yeah. The diagnostic process is definitely, it has to be a collaborative process because of the fluctuations and the context sensitivity of the clinical presentation of the person. I mean, typically the diagnostic process is no really different from the diagnostic process for anybody with personality disorders. It starts with taking history. It goes through going through different criteria and asking the person if they demonstrate certain criteria, but also interviewing them about characteristic difficulties they had in important relationships, including their experience of important people in their lives. It would also involve taking collateral information, interviewing people in the person's lives that may be able to provide additional information. Sometimes the person themselves may not be the best reporter, and also observing the interaction with them. One of the greatest sources of information is noticing how the interaction with the person unfolds and how it makes us feel. So our feelings about the person could also matter. Of course, we have to be very critical about how we take them into account. It's not a cookbook sort of a process. If I feel like this, it means the person is a narcissist. But we do take this into account when we do observe how we feel because it becomes an important source of clinical information about who this person is. Because again, a lot of what's happening with personality disorders, and especially with people with pathological narcissism, it's more about what people do and not so much what people say. So we really have to pay great attention to their behaviors, and that also means how they're affecting us and how we feel about this.
And that's a terrific segue to my next question, which is we just discussed sort of the clinical diagnosis of NPD. Yeah. What about just some basic warning signs for lay people in terms of what they might watch for in a loved one? What are some of those signs that somebody might be dealing with NPD?
It's a very good question, even though it's one of those things that I say don't try it at home, like diagnosing people around you with different disorders. It's one of the disorders that's very easy to misdiagnose others because of our own reactions. A lot of times when we feel slighted and we feel ignored, we might say, this is so narcissistic of you. And it could be, but it could also be happening for other reasons. Usually when we noticing that people have great difficulty regulating self-esteem, getting over rejections and failures, and they have very strong reactions to those experiences, one might suspect that there's something going on with self-esteem regulation that makes it hard for them to function. Also, if we notice some pattern of grandiosity, for instance, that persists, and people tend to exaggerate, usually it's not a conscious exaggeration, an intentional exaggeration, when they tend to greatly overestimate their capabilities, and that gets them in trouble, then we might suggest that maybe they have to talk to someone. Yeah.
Great questions coming in here for you. What about this one? Do you see a change in presentation as a person ages from child to adolescent to adult?
Yeah. Narcissism does change over time against the traditional opinion that it doesn't. If we read the classical myth about Narcissus, it portrays a very sad sort of a future for Narcissus, who basically dies of thirst and hunger because he's so preoccupied with his image in a stream that he's not able to pay attention to even basic needs. And that would defy even the traditional hierarchy of needs if we think about this. So the myth was very, very dramatic about this. This is such a profound preoccupation. People basically are doomed, and they have no chance for any positive future. The reality is more complicated than this. We see, and this is confirmed by a number of studies and even a recent meta-analysis about it, that pathological narcissism does change over time. The changes are usually slow, but they do occur. And usually they occur towards improvement. And the changes in vulnerable narcissism could happen slightly faster than changes in grandiose narcissism. That can be attributed to greater dismissiveness of people with a grandiose version of narcissism, and also greater capacity for attachment, in people with a vulnerable version. So I think that those things kind of play an important role in ability people to change.
We're going to talk about treatment in just a moment because obviously that's a
Of
very
course.
important part of this
Yeah.
discussion. But
Yeah.
first, how about some commonly co-occurring mental health challenges? I understand that there are some ones that are fairly prevalent.
Yeah. I mean, it's an important subject for multiple reasons. One of them is that pathological narcissism or narcissistic personality disorder usually does not come alone. Many times there are other conditions. Primarily, we find some type of a mood disorder. It could be depression or bipolar disorder or dysthymia, or what now is being called persistent depressive disorder. Anxiety disorder of any type, essentially, could be, and substance use disorders. Those are the three major classes of disorders that show up. Um, and it's usually about 50% for mood disorders, about 55% for anxiety disorders, and I put about 65% for alcohol and substance use disorders, which is substantial. So it's very likely that the person with NPD will display some other conditions. Those are not the only conditions they're likely to show up with, but those are the primary ones. The other side of this is that it's many times people with NPD get misdiagnosed, and many times they come to treatment because they say that they have something else, when in fact they have NPD. And one of the things that they get misdiagnosed with is, for example, is treatment-resistant depression or PTSD or OCD or some type of anxiety disorder like generalized anxiety disorder. And it's very possible that they have those disorders. However, it's very important to not miss the diagnosis of pathological narcissism, because if it doesn't get addressed, those other disorders are not likely to shift. And that's where the diagnostic process really comes in. So they're not mutually exclusive. So sometimes people have those other disorders, but it's important not to miss NPD as well.
A viewer would like me to ask you to talk a little bit about differential diagnosis involving NPD and autism, specifically around traits such as social cues, not picking up on emotions.
It's a very interesting subject. It's actually, they may not be mutually exclusive. And one of the issues that we find is that this characteristic feature of pathological narcissism is the formation of a grandiose self and devalued other. This is not so much happening in autistic disorders. So simply because it's organized around other experiences. The issue here is usually more about how to sustain any measure of continuity of self or continuity of self-experience, it feels almost non-existent in those conditions. In NPD, the challenge is much more complicated. It's a challenge of, I want to feel better than other people. It may not be obvious initially in the assessment because again, it's a lot of self-report, and it may take some time to recognize that whether or not this is really about putting yourself up and other people down versus it's really sustaining some measure of continuity of self-experience like we have in autism. And when it comes to differential diagnosis from a vulnerable version, same thing. We have to find out if there is a place for significant grandiosity in this presentation, which many times gets attributed to other people, feeling that I'm so small and other people are grandiose. May not so much appear in autism.
Let's shift gears and talk about treatment, because this is such an important topic and something that you do a lot of work on. Let me start with this. Are there roadblocks for somebody potentially with NPD to seek treatment? I imagine that there might be.
There might be a lot of roadblocks. One of them is what we discussed earlier, is that there's a lot of stigma. We know that stigma is a huge roadblock for essentially any condition, and any group of people that is stigmatized is not likely to come to treatment. They're afraid to be stigmatized by therapists. So one of the roadblocks is that there's a perceived stigma that may not be, the individual practitioner may not have that, but if people with NPD believe that there is one, they may not seek treatment. There may be self-stigma. They may think that they don't want to come to treatment to confront something that makes them feel so terrible about themselves. Um, and that's another issue. And another issue is that there's a difficulty sometimes seeing that they're really the ones that are contributing to the problem. So there's a tendency to externalize responsibility and not really take responsibility for their own actions. So a lot of the times when people with NPD do come to treatment, it's crisis driven. Somebody, for example, tells them, if you don't go to treatment, we will get divorced, or you cannot work in this company unless you address your interpersonal style or something like this. And in those type of behaviors, those type of circumstances could really lead to initiation of treatment, but not necessarily. One of the myths about NPD is that people with NPD do not seek treatment. That's absolutely not the case. When we review the prevalence of people with NPD in treatment, we find out that there's a relatively high prevalence of people that do seek treatment. Studies show it could vary from 8.5% to 12.5%, and in some settings it could be even 20%. And that means that that's absolutely not the case, that people do not seek treatment. So they do come to treatment. There may be some difficulty utilizing treatment for a variety of reasons. One of them is fear of change. A lot of times people are afraid of it because change poses a natural challenge to the sense of grandiosity and the illusion of perfection. Because if I'm changing, that means that I'm acknowledging that something was not perfect. So that's already a very shameful and very, very difficult experience to sustain. So a lot of times there is a resistance to change. A lot of times there is a reluctance to define specific goals because it feels like if I have a goal, I may not accomplish it. That might feel like a failure. So those type of things could really get in the way.
So once somebody does get into your office for treatment or to another practitioner's office, what do those treatment modalities look like?
It's a good question because today we are really living in the era that a lot of people are trying to develop treatments for NPD in a very thoughtful way, but we still don't have what we call evidence-based treatment. Some treatments were subjected to some form of empirical testing, but not really directly. So we could say today that we don't really have empirical basis for any of those treatments to work. So we have anecdotal evidence that a lot of treatments work. And this is a very, very exciting and hopeful era that we live in because people are finally accepting that, yes, NPD is a condition that can be treated. Some time ago, people thought, no, it's not treatable. If basically people have NPD, you are really not treatable, you cannot change. And for decades, narcissism was considered a negative prognostic sign that if somebody was narcissistic, people cannot change. So one approach to this is modify existing treatment, for instance, CBT or psychodynamic psychotherapy, or actually any other form of therapy, in a way that takes into account the nature of NPD to make it work. The assumption here is that if we're just applying any approach without tailoring into specifics of the disorder, it's not going to work. And that's usually the case. Usually treatments require some type of a tailoring. And that would require knowledge of what NPD is and what it is not, and then really making accommodations for what the patient can or cannot do in treatment and how to structure this treatment in a way that's productive. Some time ago, I published some principles that could really guide treatments like this. They're really not a-theoretical principles, they're trans-theoretical principles that help really think about any treatment from that perspective and really make accommodations. And so some of the ideas, they may seem very basic, but they really work. I mean, we really think about defining goals for the treatment. We talk about psychoeducation for the patient, like explaining what the disorder is. We're helping people develop a sense of agency or ownership of the process of treatment, helping them address behaviors that may interfere with treatment, like non-attendance or coming under influence of substances, things like that. but also addressing some of the interfering behaviors that come from therapists. One of the most powerful reasons that treatment with patients with NPD do not work is the feelings that we therapists develop about those patients. And sometimes that comes from misconceptions about the diagnosis, and sometimes it comes from the interaction in the room and difficulty making use of those negative emotions about the patient. Um, as an example, it's very common for people to develop very judgmental and critical approach to patients. For instance, if I have a patient who is very critical of everybody in their lives, I might also start feeling critical of them. And if I don't take into account my reactions and figure out how to make use of them productively in treatment, this treatment is likely to stall and I may not work with this person productively. However, it's also an opportunity to make use of my own reactions in service of the treatment and maybe promoting this treatment in such a way that helps understanding this patient deeper. I saw this a couple of times that it could also reflect, so my critical reaction to the patient could also reflect how critical this patient feels about themselves or how critical they expect others to feel about them. And sometimes it offers an opportunity to see people in a much deeper and much more three-dimensional way than we see them initially.
If I'm hearing you right, you're essentially suggesting that this field is evolving right now. You have been
Yes.
involved in it for a while now. Can you talk
Yeah.
about the trend line? Are you encouraged by what you're seeing in terms of research and discussion around these treatments?
Yeah. I'm really encouraged when I got interested in this field and when I was fresh out of the training and I got my license and I started private practice, and at that time could not pick and choose who I'm taking to my private practice. So I was taking a lot of people that a lot of patients that other colleagues didn't want to treat. So very quickly I discovered a lot of my patients have some version of pathological narcissism, and I was at that time I was very interested in evidence-based treatment for borderline personality disorder. So I said, well, BPD is just one letter away from NPD, so I could just use this approach, and why not? So many people think that that's possible. And I learned really the hard way that it's not, that there are significant differences that required accommodations. And so initially, I believe I was really a horrible therapist for my patients. And I realized that it's time to make some changes and make accommodations in those treatment approaches. And that's how it all started. And today, there is so much more optimism about the treatment that I'm really encouraged to see how much research is being done, both about the disorder, but also about the treatment.
So at this juncture, if somebody is diagnosed clinically with NPD,
Yeah.
what is the next step? I mean, does a general practitioner, a general clinician tend to refer out to a specialist? How does that work?
I think going to see a therapist who understands NPD and has some understanding of treatment methods would be probably the best bet. I mean, I would want to say seeking a specialist is probably the best possible idea, but I'm aware of the fact that we don't have a lot of specialists and we don't have a consensus what the gold standard for treatment is. But I think that like a thoughtful clinician who understands what narcissistic personality disorder is, who can deal with their own reactions to the disorder, who can deal with their own reactions to the patient and use that constructively, who can talk about treatment goals and talk about the relationship in the room. Those are really would be the kind of important capabilities to look for.
Very germane question just came in, and I want to work this in before we move forward. What recent research advancements in the neurobiology of NPD could influence future treatments?
Great question. This is also a great question given the earlier discussion about the potential genetic component here. So a lot of times people want to see if there's something biological, meaning maybe we could treat something this with medications. Well, it's more tricky than this because the dichotomy between brain and psychology no longer a dichotomy. There is so much; those things are so much intertwined. Today, we don't have a biological treatments that are specifically tested for NPD and they're specifically helpful. They can be helpful for specific symptoms, for anxiety, for depression. maybe for some other things like that. Not necessarily for the disorder itself, unlike depression, when we have certain classes of medications that would be even called antidepressants. We don't have anti-narcissistic medication that doesn't exist. So the primary treatment nowadays is still psychotherapy. Could be different, it could come from different schools of psychotherapy, but it's still psychotherapy. We have some good advancement in understanding neurobiology and brain functioning. We're still far from having very clear neurobiological theory what NPD is. But it's possible to imagine that at some point in the future, somebody might come up with an idea that maybe we can try something from that perspective and something more biological that could be developed for NPD. However, in psychiatry, we never develop medications based on some type of a model. Sometimes we develop medication first and then we have a model. So to be honest, I don't know. Maybe somebody's going to come up with something and then it will evolve into developing a biological model of what actually NPD is. So those sometimes development of medication, for instance, and development of neurobiological models, they kind of travel two separate pathways here. So I think that it's more likely that we will develop more efficient psychotherapies because I still think this is a primarily disorder that is primarily behavioral and less so biological.
Igor, I want to talk a little bit about some strategies for a loved one who is living with somebody with NPD.
Yeah.
And you
Yeah.
pointed something out, very important something earlier on, which is, we don't want family members diagnosing their loved ones. Certainly that's not the case. But let's take the hypothetical that an individual has been diagnosed with NPD and you are somebody living with that individual and supporting them and loving them. What are some strategies for being supportive and playing a positive role in that individual's life?
It's a very good question. One thing that comes to my mind is that don't read internet because that's what you find on the wider internet is so incredibly condemning and so negative that it may seem like that you cannot have relationships with people with NPD. That's not true. You cannot be married to somebody with NPD. That's not true. And you cannot raise children with somebody with NPD. It's also not true. We don't have specific research that says that it's impossible. Sure, there could be challenges, but it does not mean it's really impossible. And some studies actually show that it's not clear that if there's actual dysfunction in those areas. One area that's really important to appreciate is that separating the outcomes of people's behaviors from the intentions. We all tend to presume that the outcome of the behavior is the same as the intention. So if somebody's hurting my feelings, it's very easy to jump to a conclusion that this person is doing this intentionally. And with people with NPD, it's especially difficult because we could easily presume that they're doing something intentional to us. They're ignoring us intentionally. They are hurting our feelings intentionally. And it may be much more complicated than this. Because it may be that this is how they are organizing their self-esteem. They're not intentionally trying to hurt our feelings. It's an unfortunate side effect of what they're doing. It's undesired side effect. It's something for them to be maybe cognizant of or address, but it may not be intentional. And I can tell you that that's an important message that a lot of things may not be intentional, that this is how this person is, and also thinking about difficulties in a relationship as an opportunity for growth, and also that it's probably a reflection of the difficulties that the person is having with their self-esteem. So if difficulties come up in a relationship, it's probably correlating with how difficult it is for this person to regulate their own self-esteem. It comes up a lot of times. When I have patients that they describe their intimate relationships with their significant others and they have NPD, they might say, well, it's interesting. I became much more critical about my partner when I had challenges at work and I had challenges with my own self-esteem. How interesting I'm doing this. And in a retrospect, it's an important observation, but it comes up so much that there's a complexity to why people become difficult in relationships, so to speak.
We often tend to have a lot of educators in our audiences for these webinars. So I do want to ask a question on behalf of that community.
Yeah.
Do you find that educators are equipped with awareness and education tools to recognize potential narcissism and NPD in younger students?
I think we don't have enough research to talk about what it looks like in younger generation. I mean, there's some very, very, very limited sort of literature about presentation of NPD in children and adolescents. Most of the research has been done in adults. You can definitely diagnose NPD and even in children, like little children, like 5, 6. But it doesn't, but again, it's usually done by professionals and it's tricky. We don't really have much knowledge about that area. So I would defer to clinicians to kind of to assess and make that assessment.
And Igor, this question is a little tangential, and you may or may not have an answer for it, but let me go ahead and run it by you. Some researchers have proposed communal narcissism, where individuals act entitled and superior because they are supposedly helping others through charity, academia, science, etc. Is this just a form of grandiose narcissism, or is it fair to categorize it separately?
That's a great question. The literature about this is really quickly developing. It's also an international literature, and this is a question that requires international perspective for one reason, specifically because we live in a very individualistic culture, and in our culture, we're more familiar with the more individualistic presentation of narcissism, which is a grandiose version of narcissism. A more communal form of narcissism it presents like I'm dedicating my life to some social causes, to social justice, to morality, helping others. And the well-being of the group is more important than anything else. But it's interesting because the studies show that it's at that point the group starts acting like an individual with grandiose version. So, for instance, if the group interest becomes jeopardized, this is when the group tends to respond in a very aggressive way, the same way that somebody with a grandiose version of narcissism might. Research shows that when we compare communal version of narcissism to grandiose version of narcissism, they overlap in 2 out of 3 parameters.
Mm.
We can talk about narcissism as essentially intersect of grandiosity, of agentic aspect of it, like antagonistic aspect of this and neurotic aspect of this. And the neurotic aspect is missing from the communal narcissism. So it may seem like those are the people that are more agentic and antagonistic, actually more aggressive, actually, and grandiose in seeking self-enhancement, but they're lacking the insecurity. And so to them, it probably feels great, but it actually, some people say that this is actually another version of grandiose narcissism. It's another way in which they may be channeling that in a way that may seem socially acceptable because it also gives them sense of acceptance. But in some of the other literature would also describe that there are actually significant differences between the two. And even genetic studies about this suggested that those may be somewhat interrelated, but actually quite different presentations of narcissism. So I think it's complex, and I think we're still at the beginning of researching this, and there's some support for both claims that there's a difference and similarity, but I also think that there's something to be said about this as yet another strategy in which people with grandiose narcissism channel the grandiosity in a way that could seem more socially acceptable.
So many questions coming in for you, Igor, and we are sort of running out of time. So let me just jump around a little bit if you don't mind. Do environmental factors such as childhood trauma play a role in NPD?
Absolutely. There is substantial, I would say there's some research that shows that childhood abuse, including childhood neglect, could really contribute to development of pathological narcissism. Absolutely.
What about any differences in presentation between genders when it comes to NPD? Do they present differently?
I'm not sure we could say that also because of how the criteria have been written. But what we can say is the following, is that when we talk about a grandiose version, it tends to present more frequently in males than in females. Again, this is a very tricky research because we're talking about cisgendered presentation, and it may be more complicated for people that are changing their gender, for instance. But when we talk about males and females, the grandiose version would have a slightly more people in a slightly more males with a grandiose presentation. With the vulnerable version, there's a relatively same amount, there's a relatively equal presentation. However, if you think about if you're writing more ambiguous clinical presentations of patients, you find that people tend to overdiagnose people with that are male patients with a more grandiose version, even though they may not fully meet the criteria, and they tend to diagnose. And then they tend to not diagnose the same patients if this is a female patient, if they have a sort of like a kind of they're on the verge essentially of meeting the criteria. So when it's more of there is some ambiguity whether or not the patient is meeting the criteria or not, patients tend to kind of follow the gender essentially base rate as opposed to the clinical presentation. So some of the difficulty here is that in our own mind, we might have a difficulty disentangling the gender from the diagnosis. It's quite interesting to think about this because some of that is so embedded in our culture. If you think about the movie Devils Wear Prada, this is actually a very interesting statement that Meryl Streep character says that at some point. She says, if this that she felt very much judged for being so career preoccupied, but she was saying that if she was a guy, nobody would judge her so much. So she was really speaking to the societal judgments about gender, that the same traits that could be attributed to relatively normal traits in one gender, for instance, being ambitious and preoccupied with work in men, could be easily pathologized in women and treated as this form of pathology. And so it's something to do more research about, and for us clinicians to be more cognizant so we don't fall for some of those judgments and assumptions that we make about gender and pathology.
What about resources as we start to wind things down here? This is obviously an incredibly complex topic, and I think a lot of people who are watching right now are going to want to learn more. Where can we point them? Do you have favorite books, organizations that are doing work around this? Anything that you want to put out there for our viewers?
I don't know how publicly that available here at McLean. I usually distribute there is essentially a booklet developed by Elsa Roningstam, which is a psychoeducational resource for essentially for anybody about NPD, which is sort of like a brief description of what NPD is and is using non-judgmental language. I don't think that there are some really good books about this. It's really problematic that we don't have the same way that people wrote books, for example, about borderline personality disorder. Some of that has to do with destigmatizing movement that occurred with borderline personality disorder, not so much with NPD. So when the destigmatization occurred, part of that movement was publishing a lot of books that were based in good science and written by professionals, and were written in such a way that invited people to develop sympathetic view about NPD. About BPD, I'm sorry. We don't have the same issue with NPD. We're still at the beginning of that process. I'm hoping that we could promote more destigmatization and invite people to write something more coherent about this. So anything with the .gov probably is a better resource than something that you find on general websites. A lot of times people maintain different websites, and it's hard to separate personal opinion and personal experiences from something a little bit more evidence-based.
Finally, I want to bring things full circle, Igor. We talked at the beginning of this webinar about the fact that there are healthy forms of narcissism, and that self-esteem obviously is something we all need. What has your research taught you about healthy self-esteem, about healthy narcissism, if you will?
Well, healthy narcissism is a great thing. We always want to engage healthy narcissism in our patients to move forward and move forward with their lives. For example, we want to engage their a sense of agency, for instance, in their motivation to improve, to do things better, um, to be ambitious. For instance, the sense of humor, for instance, or charisma. Those are good examples of healthy narcissism. And it's usually intertwined with the less healthy versions of narcissism. So we really want to sort of help people move towards that. So that's what I can say. But
Igor, I want to thank you so much for being our guest today. We very much appreciate your time and your commitment to helping educate folks about this extremely important and often misunderstood topic.
thank you so much for having me. And thank you for making room for this seminar.
Of course, Dr. Igor Weinberg, and to those of you watching, thank you for your interest in our educational webinar series. We hope you'll come back for our future sessions, and we wish you a wonderful day.